as all of us face different challenges during our career, especially in the early phase of career, even in a in a late phase as well. But the earlier challenges are quite different and quite important, and we have to go through them just to reach to the next level. So I have got very good young speakers who are going to talk about different subspecialties, because they all are doing great work in their respective subspecialties. I have Dr. Nidhi Gadkar, who's a cornea surgeon, and she's working at Kashyap Memorial Eye Hospital in Ranchi, right? Yeah, sorry. Dr. Shivani is there. She's a glaucoma and cataract surgeon at SRJ Netralaya, Indore. We have Dr. Kushagra Jain. He's a vitreoretina surgeon, UVA and ROP specialist, and also director of SRJ Netralaya, Indore. I have Dr. Subhajit Bhattacharya, who's a pediatric ophthalmologist and pediatric eye surgeon working in Kolkata. And we will be having Dr. Rutuja, she is an excellent orbit-oculoplasty and facial aesthetic surgeon in Delhi. So we'll start having Dr. Nidhi first. Yeah. Hello. Jhed mein uske baad next. Can you remove my?
Thank you, Dr. Nikunj, for inviting me in this IC. So I will be talking about my journey as a cornea surgeon. I'm Dr. Nidhi Gadkar. So I did my MS at Ahmedabad, followed by a cornea fellowship at Barakpur Disha Eye Hospital. So few questions which I thought when I was starting, and I hope that you would get the answers at the end of the presentation. Is cornea fellowship fruitful? What additional skills should I have? Now, if this is a referral branch, how would I primarily get my patients? So cornea involves a lot of pathologies. It involves treating trauma, surface disorders, dry eye, dystrophies, corneal erosions, allergic conjunctivitis, ectasias, decompensations, and of course cataracts and much more. So what happened when I joined private practice? Honestly, I was clueless. There are so many things which are available in an institutional setup when you're doing your fellowship that you do not really realize how much armamentarium you actually do require. So my mantra was replicate what I learned, reproduce, elaborate, and then evolve. Starting with my instruments and machines, I went back to my fellowship days. All the instruments that I had been operating on, I chose them. I was comfortable working on them. I started making sets for clean and infected procedures, very important for cornea surgeons, as we have a lot of infected cases that we need to do. And as the workload increases, you can increase the number of these sets. I got a microscope of my own for my own scraping and staining, because sometimes I felt that the lab reports were not very reliable. Next thing was to attach myself to a microbiology and pathology lab. These are adjuncts but absolutely necessary in the diagnosis, treatment, and prognostication of the kind of cases we need to cater to. Corneal tissue, very important for, most important for a corneal surgeon. Where to get it, how to get it, when to get it. So if your hospital already has a HOTA certification, it makes things easier. Else you have to start working on that. Meanwhile, you can get attached to another center having the permission and do the cases at that center. Now, iBank setup is very important. Prepare a team for retrieval and always prepare a backup, because you will need this 24/7. Sometimes when my staff is not available, I myself have to go and collect the tissues. It's good to always get attached to a hospital for hospital cornea retrieval program. Patient counseling is very important, especially if this is a newer specialty introduced in your hospital or if you are a newer surgeon. Definitely needs more chair time, more counseling, proper counseling. Do not omit the risk and complications of the fear of losing the patient. Follow-ups, long-term treatment should be explained beforehand in cornea practice, and do not promise what you cannot deliver. Case selection, again, very important in your initial stages. There might not be a stratification in your private practice like there is in an institute, where you might be getting the cases according to your skill. So here, every case that comes is a new case. It's best in the initial phases to take a good prognosis case or uncomplicated cases so that you can deliver. So always pick your battles wisely. Now, it is important to record the clinical pictures and your videos, because you can learn from your own videos. Corneal diagrams do exist, but honestly, sometimes you do forget how the exact look was at the previous follow-up, and it is very important, and it is very good to go back at the previous picture and see it. It also helps to counsel your patients and medico-legally saves you. If you are confused, do not hesitate to take a second opinion. Your teachers will be always available on WhatsApp, on phone, otherwise as well. So it is always better to take a second opinion if you are not finding a solution to your case. As a cornea surgeon, keep your armamentarium ready. You do not know what lies beneath. You might need anything. So a backup should always be ready. Now, this is quite remunerating, be it globe salvaging or be it giving good vision to the patient. Am I 8 minutes over?
4 minutes over.
Okay.
So we'll give you 2 more.
Yeah.
Because then we are going to do short.
Yeah. Now, learn from your own mistakes. These are few cases that I did in my initial practice. Lens coming out, cutting off the iris during a therapeutic keratoplasty. This case is of a 100-year-old man undergoing therapeutic keratoplasty. I don't know why I tried to save an intumescent lens, and there it ruptured during the suturing, and I had to go back and remove it. Always keep tissue backup, especially if you are doing lamellar keratoplasties. So this was a case. I had a perforation. Thankfully, I could salvage the tissue by dissecting from the other side, but it might not happen all the time. Sometimes the perforation might be quite large and you might not be able to salvage the tissue. And then you have an open eye on the table and no tissue. So maybe you can have 2 procedures kept. One is non-emergency, one is lamellar, and once you dissect the first tissue, then you're good to go for the full thickness procedure. Wet lab practice, again, very important. Whenever you have spare time, whenever you have spare tissue, you can go for it. It will improve your tissue handling, improve your technique, reduce your surgical time, especially for suturing, desec lenticular dissection, or DM peeling. Wet lab will really help. So I think this is how wet lab helped me, starting with uncomplicated cases, DSEC, and progressing to air-assisted cases in vitrectomized eyes and post-SFIOL. Keep acquiring newer skills. Now, this is what I learned to decrease my dependence on a VR surgeon. I can make my own ports and at least do a core vitrectomy when the AC is flat or the IOP is very high in spite of mannitol. And this really helped me, because this was a case where the lens was going to get expulsed. Reaction time was very less. We did not have the VR surgeon, and here I could salvage the lens and do my own vitrectomy, and the patient did well thereafter.
Dr. Nidhi, can you sum up?
Yeah. Similarly, single throw pupilloplasty, post-optical cases, a little tricky, but it gives very good outcome anatomically as well as functionally. Endoilluminator, again, is a friend of a cornea surgeon. Low visibility, it really helps. You can fix it pars plana and use it externally as well. Now, don't worry about cataracts, that we all do. Your complicated cases will come back to you, and non-complicated will also come back to you. So these are cases that I treated, and they came back to me only for their cataract surgery, and thankfully they did do well. So keep achieving new milestones in your journey, because excellence is a journey with no destination. Thank you so much.
Amazing talk, Dr. Nidhi. If we have some time, we'll have a discussion at the end. Let's move to the next speaker. Dr. Shivani Dikshit. She'll be talking about.
Good morning, everybody. I'm Dr. Kushagra Jain. I'm Director and Vitreoretinal Surgeon, and I take care of yoga and ROP services at SRJ Netralaya, Indore. So, a very interesting topic. Thank you, Dr. NIKUNJ, for this topic. I'm going to discuss my journey as a vitreoretinal surgeon till now. It's been a very short journey, but I'll still discuss whatever learnings I can give from my journey. So, just how the seed of treating the vitreous got sown. So I entered my MBBS in 6600 BC, and I passed in 2017. A few people smiling here. All right. So I passed my MS Ophthalmology from MNJ Regional Institute of Ophthalmology in Ahmedabad, and just trying to assess what I will be doing later as a subspecialty. And the final year of my MS, I had two postings, one of cornea and one of retina, and these were the two most interesting subspecialties to me. And somehow I was very close to one of my cornea consultants. I'm sure a lot of you know her, and she just asked me once. I can see Nidhi smiling. So yeah, she just asked me once whether, what are you going to go for? Do you want to go for cornea or something? And I just told her that, I want to go for retina when I'm done with my ophthalmology. And she just looked at me and said, why not cornea? So I told her, what do you feel when you look at the cornea? So she's like, it just looks beautiful to me. So I told her ki I was in my retina posting just few months before I was with you, and I held a 90 diopter lens in my hand, and I saw the retina through the slit lamp, and I could feel that I'm sitting inside the vitreous cavity and I'm just looking at the retina. That's why I've put this picture. This is what I could see so close, up close, and I was just amazed by it. So I knew then and there that it was something like love at first sight, and I had to go for retina, and there was nothing else that I would have wanted to go for. And at this point of time, there was no other criteria in my mind, no financial things, no setup cost or any other thing that was in my mind at that point of time. I knew that this was what I wanted to do. And another thing that really helped me is consultants at MNJ did give me hands-on core vitrectomy and endolaser during my MS. So that really enforced that thing. So then I really got into thinking and think, why should retina be really considered? And these are the usual suspects that you think about when you think of a subspecialty. First of all is definitely interest. That is what starts the whole discussion. Then you think about how the learning curve is going to be, because the learning curve in different subspecialties in ophthalmology is completely different. And so many of subspecialties have now propped up, and the learning curve is totally different. The fellowship durations are different. The manner of practice in all of them are extremely different from each other. Working hours and emergencies are more or less the same in all of them. So I don't think that will matter too much. One more thing that will matter a lot is the setup cost and the return on investment, because once if you're joining an institute or a private practice, then the setup cost and return on investment is something that you don't think about. But if you want to set up your own hospital, and this is one of the major things that you will have to think about. So this is one major thing. And when it comes to retina, the setup cost, I think, is the hugest when it comes to ophthalmology. I will deal with the equipments a little later on the next slides. But yeah, the one point that was very important for me is what to think, that was this the need of the hour. So I was thinking whether retina is it the right time to go for a retina practice, and it also depends on where you want to practice later on. So if you want to practice at some place where there aren't many retina surgeons, then obviously you would be motivated to take up a subspecialty. There are not many people doing it. And fortunately or unfortunately, there were a lot many like me who in my city have taken up retina, and then there are a lot many retina surgeons, and there's a very healthy competition going on right now. So that's very good. So I think the last point is probably the most important thing that you will help you to decide what to take up. So now coming to the fellowship, once it was decided, now fellowship is your foundation for how you want to go about it. And obviously there is going to be some healthy competition initially. There is a battle of first, who is going to give the first, I don't know, who's going to do the first laser, who's going to do the first ports, and all sorts of things, all sorts of steps. And this is a very healthy competition, and you have friends, you have fellows around you, and it's always better to learn from them, learn from your teachers. Unfortunately, there is also an unhealthy side to it, and there is, specifically in my fellowship, I remember there was a lot of issues going on with who's going to be posted with what surgeon, how many surgeries are you going to get, and things like that. So survival of the fittest. So then you have an option whether you're going to want to go and join an institute and practice as an institutional practice, whether you want to join a private hospital or you want to start your own practice. So that is something that is, I feel, a very personal decision. So I will not go into the details of who wants to do what, because that is actually a very personal decision, and a lot of family issues and family things will also decide that for you. So coming up to the equipment, because I personally have set up my own hospital, so this was a very time-taking process for me and a very important process for me. I did a lot of research on this. So a journey of a young retina surgeon, I think this is a very important point to consider, what equipment to buy, because there are so many equipment in retinal practice that you really need to know what you need and so there are so many equipments that you want to buy, but of course you can't buy anything. There are so many brands that you want to go for, but obviously budget becomes an issue when you have to buy so many equipments. So a lot of research needs to be done on this. So this is just a list of what all basic things that you need for starting retina practice. OCT is primarily the one thing that we need the most, and there are a lot of equipments, there are a lot of cheap and expensive equipments. The two major things that you need to think about is whether you want to go for a spectral domain OCT or an SD OCT or a swept source OCT. So that is one thing that you will definitely need.
7 minutes. So can you sum up quickly?
So a angiography machine, a fundus camera, a laser, a vitrectomy machine, the microscope and biome, obviously, the B scan, wide fundus. There's some things that you can probably avoid in the first go. Octa is something that you will want to avoid. A wide field fundus imaging is definitely can be avoided. Surgical recording device, I went up for it a little late, but I think it's a very good thing to have in the beginning. So this is I just took my phone to the next level like 2 years back, and this is what my research was at that point of time. Totally haywire. So yeah, I think this is probably the last slide that I will cover. The first thing that is the most important for a retinal surgeon or for anybody is how the patient acquisition. That is probably the toughest job for us as young surgeons, right? So there are these things that matter a lot. The location of your setup, you have to show your presence, you have to meet other doctors, other endocrinologists, rheumatologists, pediatricians. You have to conduct camps. Social media is a very important tool right now. Of course, with time, mouth-to-mouth publicity happens. Advertisements right now are, everybody is doing it. And just the last slide. So these are the initial goals that you can start off with. If you take care of these 10 points, then I think you're heading into the right direction. Stick to a protocol. Whenever you're trying to treat a disease in your early years, please make a protocol for everything and just stick to it. When you stick to a protocol, you're bound to do the right thing for the patient. Don't hesitate to investigate. Initially, you find it difficult to ask the patient to get an investigation done. Don't hesitate. Go with it. Go with your gut. Trust your training. You've learned it. You've seen it. You know it. You just have to implement it. Appropriate surgical selection of cases is what Nidhi also told. It's very, very important. So surgical instrumentation has to be absolutely perfect. You're not that perfect. Your surgical instrumentation has to make up for your imperfections. Don't hesitate to ask for help. Surgical videos, you need to check and recheck and see them. Counseling is definitely the most important part. When you counsel your patients well, whatever you do, they're going to remain with you. You're going to treat them well. I'm going to skip the cases. I'm just going to end with this last thing. Ethics is, knowing the difference between what you have a right to do and what is right to do. If you keep your ethics in mind in the beginning, you're definitely going to head in the right direction. And one thing that my father always told me, be true to the patient. Always remember. Right? Thank you.
Thank you so much, Dr. Kushag. That was an amazing talk. Moving on, we have Dr. Shivani. She'll be talking about her.
Good morning. Thank you for designing this beautiful IC, NIKUNJ. Preparation of this talk really made me nostalgic as I was digging into my older surgical videos and photographs. So I completed my MS in ophthalmology from SMS Medical College, Jaipur. Then I pursued my long-term fellowship from Narayana Nethralaya, Bangalore. Why glaucoma? We know that it's defined as optic neuropathy and all, but to look for those subtle changes in the discs and to know those causes of glaucoma really makes this branch interesting for me. Every eye is different. Sorry. And also we know very less about this disease. The only modifiable factor that we know is intraocular pressure. All our treatment revolves around just that. So did my PG, did my fellowship, felt pretty elated. When I stepped out seeking for job opportunities, I got the reality check. It was just the beginning. After fellowship, I was pretty confident in handling those gray areas, when to treat, when to observe, those nightmare reports, which I really found very difficult in my PG days. I got the hold of them, did hundreds and thousands of gonioscopies, PIs, knew how to play with anti-glaucoma medications. Regarding surgery, when to plan TRAB and the post-operative bleb maneuvers. Okay, everything is covered? I don't think so. Was I actually confident in handling those difficult glaucoma cases independently, especially single-eyed patients, advanced glaucomas, going for valve implantations? I was fortunate that I got an opportunity to work as a consultant at AIOC2023. I really grew as a clinician, as a surgeon, and most importantly, I made some friends for life there. Moving on to the clinical talk now. So just sharing a video here. A routine case of combined surgery was taking my superior rectus suture, and when I started doing peritomy, I realized that there was a partial thickness conjunctival tear in the left bottom of the screen. Anyways, I continued with the surgery. So even though it's a partial tear, you need to repair it for a good bleb outcome. I proceeded with the surgery. After doing the bleb closure, suturing it to the limbus, I closed this tear with a 10-0 vicryl suture with interlocking continuous suturing technique, and this patient did well post-operatively. So how to avoid these situations? Very, very important. Please respect the conjunctiva. Gentle tissue handling is a must. We often use limb forceps for peritomy and other surgeries, but as a glaucoma person, I cannot emphasize enough that you use atraumatic forceps. So just an example here, I'm using Pierce-Hoskin forceps to hold the conjunctiva. Take your time, make a clean nick at the limbus when you go with your peritomy. Being bidextrous really helps. You can use that scissor in your left hand and do a good dissection. Know your instruments, like I'm using a Westcott scissor with blunt tip here, so you have minimal bleeding when you do subconjunctival dissection. You go more posteriorly to get a posterior filtering bleb. Pre-operative planning is a must. Please just take a couple of seconds to have a look at the conjunctiva before you take the patient into the OT, whether it's mobile or it's scarred. Just sharing an example here, I was taking this pseudophakic eye, very refractory glaucoma for trabeculectomy. She had a lot of hyperemia, as you can see. And on having a closer look, you can see that even though she had undergone phaco before, but there was scarred conjunctiva. So I had the plan in my mind. I used a higher concentration of mitomycin C, avoided this location, performed a superior trap. And in such cases, corneal traction suture also helps. So it avoids further unwanted manipulation. You take an 8-0 vicryl suture with a spatulated needle, gently take a partial thickness bite of the cornea parallel to the limbus. You can clamp it inferiorly, and there you have such a good view for your surgery. One of the areas of struggle for me, during my institutional training, all my mentors were performing same-site combined surgery, so did I. But I often ended up with leaky main ports, which led to poor interior chamber stability, a lot of wound hydration. I was anyways performing temporal phacoemulsification, so I switched to twin-site, superiorly trap and temporal phaco, and I ended up with much controlled closing of my cases. As a glaucoma person, we are often concerned about, if we'll have an overfiltering or a nearly flat bleb. So releasable sutures come to our aid here. Just a small video. So this is a 10-0 nylon suture. You are passing the needle just similar to that traction suture bite. Again, the needle is passed through the cornea. It comes out through your scleral flap. All these bites are partial thickness bites. For the third bite, you pass it through the edge of the flap, come out through the adjacent sclera. You have taken 3 bites now. So when you pull the suture, it is important to leave this loop here, because you will take 4 throws and use this loop to tie your releasable. You just trim this end, keep it long so that you can tighten or loosen the suture before your final closure. Check for bleb leak at the end. It's always a good idea whether you have a watertight bleb. And then finally, you just trim that corneal end of the releasable suture and you close the case. So to remove it is as important as to apply the suture. In OPD, just hold the lid with your left hand. Ask the patient to look down. With a 26 gauge needle, you can just take out this loop. Now you have this free end of the suture. Just gently hold it with a plain forceps and wriggle it out. So checking for bleb leak always prior to going for releasable removal. See how gently I'm just giving massage temporal to the bleb area, never on the bleb area, and you have a good bleb. One very, very important slide, I asked one of my fellows just to share her journey, what were her challenges, and I've actually put up her notes. So this emphasizes that, just like any other surgery, you have to know your patient, you have to counsel your patient, you have to be on the same page because you are handling a very difficult disease here. You have to inform your patient that glaucoma is not curable. All the treatment is to save the remaining vision. And patients often compare such surgeries with the cataract surgery. So please talk about the sequelae, and they might have to come for reprocedures, anti-glaucoma medications in future. It's a lifelong follow-up pattern. Often you have such patients who have really advanced glaucoma, so you have to go for a holistic approach, motivate them for a healthier tomorrow. Thank you. I had to run really fast for the time restraints.
So yeah, you finished in time. Thank you so much. Yeah. Next we have Dr. Subhan.
Thank you, Nikunj, for inviting me over here. Okay. So when we are talking about journey, it's a very personalized thing. So I feel the ultimate goal, it's not the journey, it's the reaching the correct destination. And that is nirvana, according to me. That is peace of mind and stability. So my journey had been a long one. I started from RIO Calcutta, then my residency DNB at SN Chennai. My fellowship was from Shankarnetra Kolkata. Then along with Nikunj and Shivani, I was fortunate to work at Sitapur Eye Hospital for a significant amount of time, and currently I'm working at Disha Eye Hospital. So that is the thought that comes to us initially in our PG days, not another bacha. I mean, it's time consuming, patients, it's difficult to see them, examine them. There's not, later on in our practice, we realized it's not much revenue generating as well. And there's a lot of emotional aspect involved as well. So why pediatric ophthalmology? So for me, it was I had a few of my own reasons. So it was 6 months of posting at RIO Calcutta in my DO days, and then I got exposed to one of the few of the best pediatric ophthalmologists when I was in SN Chennai. As a person, I had a type B personality. I have a type B personality. I was friendly with children. That's what I felt. And of course, you need to have empathy, and you need to rule out your interest in other specialties. I realized that I cannot do much of VR, and I couldn't see the corneal layers. So I realized, okay, pediatric ophthalmology could be good with me because I was good at squints. So making the best out of your fellowship, it's important, because this is the time when you actually learn. You observe your consultants. Your seniors are the best teachers. And remember that less is more. If you're getting less cases, doesn't mean that you're learning less. You learn, you get and grab the most out of it. Always maintain your logbooks. See as many videos and record your own videos and do your own surgical planning. My mentor used to say, to be a good pediatric ophthalmology, you need to be a good adult ophthalmologist first. I think that's very important, to be a comprehensive ophthalmologist for everything. So handling in children in OPD, it's again, you have to use your charm and small talks and baby talks. Always greet it with a smile. and you can never say that the child is uncooperative. I mean, no matter what, you have to make the child cooperative. And then after fellowship, it was actually the real world. So basically I jumped into the sea. It was a leap of faith. I started along with my wife, actually she's also a pediatric ophthalmologist. I started the dormant pediatric ophthalmology department at Sitapur Eye Hospital, where we had more than 100 children at the OPD and variety of surgical cases without any backup, no restriction, complete independence. So it really helped us in the long run. And just coming to a few clinical scenarios which I felt and I struggled a lot to adjust initial days. So yeah, lensectomy, it's difficult to do lensectomy with a forceps or a cystitome. So generally I use cutter for both anterior axis and posterior axis. Make sure that the rim is well sized, because almost every case end up with a capsular phimosis. And the most important thing is the parents counseling, because eventually if you don't counsel the patients and the child doesn't wear the phakic glasses and all, then it's all for nothing. So coming on to another very routine day-to-day procedure, it's a lens aspiration. So again, optimum rhexis was difficult initial days, all the centripetal pull. So I ended up having a lot of extensions which could be easily managed with a cut. So I initially had those palpitations of rhexis extension, but the ultimate outcome didn't matter at all. So even in very small kids, when the rhexis is very brittle, so I used to use cutter all the time, and if you see, eventually the rhexis is pretty smooth and round. So coming on to the posterior rhexis, it used to give me a lot of palpitations in my fellowship days. Especially my mentor was pretty strict. She used to stand on my head, and I used to have scary thoughts. So the initial, what I learned in my fellowship days was a manual PCC, like the video shown over here. And later in my journey, I just adopted to the retroaisle capsular rhexis with a cutter, which was easy, which was comfortable, and the outcome was absolutely the same, even the long-term outcome. So the rhexis was round, and you could actually easily put the IOL in the bag. Sometimes occasional surprise cases were there, like membranous cataracts and pre-existing PC defects. You can see the typical sign, fishtail sign of the pre-existing PC defect, the cortical, the powdery substances. It's basically vitreous stained with the cortical matter. And traumatic cataracts are I had the most fabulous experience learning from traumatic cataracts. It enhances you as a surgeon. So fortunately for me and unfortunately for the patients, I had a lot of traumatic cataracts. Every week we had 2 to 3 traumatic cataracts at Sitapur. So I made an archive out of that. I'm not going to go into details. So it was such an interesting to follow up these patients, how they're doing. And strabismus is altogether different ball game. So in my journey, I just made a few pearls. That squint, which I learned that squint measurement and planning is more important than the actual surgery. And I learned it the hard way. Never change your surgical plan intra-operative. You end up with the wrong unpredictable results. And I always prefer bilateral surgeries over unilateral R&R. So this is again an important thing for squint specialists, because bilateral surgeries are usually done under GA. But personally, what we did was we used to do under LA only, one eye initially, then do my cataracts, and then end of the day I used to go for the other eye. So that's how we could manage pretty well bilateral adult cases. And always document your pre and post-op photos for the patient as well as for your own satisfaction. Just a few tips of risk. Okay, I'll just I won't go into the details of this. So we had a lot of difficult strabismus cases, and you should all have this under your repertoire. So you should know all these difficult cases, and once in a lifetime you should be able to do it. And I think that's more like it. And the future of strabismus is everything is becoming minimally invasive. So strabismus surgery as well, we are currently using only fornix incision and glue to close it. So what I missed in my fellowship, I feel as is ki I didn't do too many publications, and I could have learned CNLDO and ROP screening. That really helps in the private practice. So the real world currently where I'm working, it's different. It's a lot of adult phacos and premium IOLs. It's 90% of the practice. Pediatric practice would be like 10% of it, and complex strabismus is only a few in a year. So be prepared for the real world as well, like do your enhance on your cataract skills. Just to conclude, you make your own journey and know what you want from life, define your own destination. I was lucky enough to work with my wife, who is also a pediatric ophthalmologist. I learned a lot from her, and I had a small pediatric person in our family as well, whom we experiment on. So yeah, thank you so much.
That's an amazing. Thank you so much, Dr. Subhajit. Amazing talk. We have next Dr. Rutuja Thomas Grover.
For including me in this IC, and being one of his good friends, he has to include me because I'm an oculoplastic surgeon and we are a rare species. So I'll be talking about the journey of an oculoplastic surgeon. What I realized, I'm not at the end, of course, but somewhere in the first 1/3 of the journey, is that there's no rule book for success. But the most important thing is to learn from your mistakes. With respect to oculoplastics, I'll be just talking about it with respect to eyelids, the orbit, oncology, aesthetics, and lacrimal. Before we go into this, however, the most important thing is the basics. It's important that when you enter an oculoplastics fellowship, that you're well versed with tissue handling. So handling the skin, the various underlying tissues, the sac, and it's important to know all your suturing techniques, be it interrupted, continuous, subcuticular, interlocking. These are all techniques we use on a daily basis. The other thing that your fellowship teaches you is how to differentiate between normal and abnormal tissue. So it's important that you are a safe surgeon and you do exactly what's best for your patient. The other thing you realize is that not only your preceptor of your fellowship or your consultant teaches you, you learn the maximum from your seniors. So when your consultant is gone out for tea, the only person who is there to help you is your senior. So you learn the maximum from the person who is just ahead of you in the fellowship, whether it is surgery or even interpreting a CT, MRI. It's important that you look towards your seniors for help. Transitioning from old to new. So when you work with an older practitioner, you realize the things that they have not been exposed to recently. So whether it is transitioning from naked eye surgery to using an operating microscope to operate, most oculoplastic surgeons now are getting better mobility and visualization because they are using nice sleek loops which are very comfortable these days. And also shifting from performing external DCRs to endonasal endoscopic DCRs. These are things which you learn to become comfortable with the help of a fellowship. So before you go ahead and become an independent surgeon, it's important that you know how to assist, because if you don't know how to assist, you don't know how to make your assistant assist you later. So once you become a good assistant, then you know how to make yourself comfortable when you go back to your own practice. Finally, operating under supervision. It's important not to get stressed or anxious while you're operating, because in that, only if you're in a little bit of a Zen mode can you take instructions from your mentor. So go ahead with a clear mind, revise all the steps of surgery while you scrub for the case, and you shouldn't have any issues. Finally, going back to your practice and teaching others. This is probably, I feel, till now the best way of learning, because there were things which our fellow did which I didn't even know was possible. So you learn, you get your learning curve cut short by teaching others. Learning to do things the right way. So some patients that you see who have been operated elsewhere, who've not undergone, let's say, a proper margin excision or a proper histopathological examination. These are the things which you learn in a fellowship. how to document histopathology well, how to send a proper sample, how to cryo the edges where you're supposed to, whether it is double freeze thaw, triple freeze thaw, whatever technique you're supposed to use. These are the things which are learnt best by doing a fellowship. With respect to oncology, it's not something which is practiced everywhere. So if you learn it in your fellowship, you could be one of those few people who ties up with a nice multi-specialty hospital and starts a good oncology practice, and then you can be the watershed area for oncology. So it's not something which everybody does, but once you do it, once you follow a protocol-based therapy, you can offer the best results to patients. The other thing you learn in a fellowship is very rare thing. So for example, this is a time when I was allowed to do intra-arterial chemotherapy. I had no idea what it was. I had no clue what it involved. But once I went with the interventional neuroradiologists and did the procedure, then it was something which I could safely say that, okay, once I saw the follow-ups, that this works, I can advise it to patients, and it's not just a frivolous or expensive thing. Aesthetics is something which is sort of coming up in oculoplastics these days, wherein people are tending to oculofacial aesthetics. So it's a branch which people are starting to get exposure to. I know it's there in Shankar Dev Netralaya, for example. They do emphasize it a lot. It's coming up in LV Prasad. It's also there in Narayan Netralaya. So it's something which we really need to focus on. This would be a separate talk in itself, aesthetics, but if you don't offer aesthetics, you sort of lose out on a lot of patients, because there's something which is very important now, that is the post-LASIK aesthetics. People who are getting rid of their glasses, they sort of end up noticing all their flaws. So if your refractive surgeon is not able to send you your these kind of patients who are worried about their dark circles or their hollow appearance of their eyes, you tend to lose out on patients. So it's important that you brush up on your basic dermatology, that is with respect to cosmeceuticals like sunscreens, basic serums, so that this is also something that you can cover in your practice. Academic opportunities are something which help you grow. So this is a cadaver dissection course that we had conducted for eyelid reconstruction. So in the process of teaching general ophthalmologists eyelid reconstruction, I ended up learning a lot based on their doubts, that where would we get tissue for this, or if we had less tissue, what would we do? So this is another good way of learning.
Rutuja, can you sum up in a minute?
Okay, the last would be instruction courses like this, which are very useful during your fellowship. And of course, here we're looking happy about collecting data for an Excel sheet, but this is something which actually helps you going forward to publish. And what I would like to say is, with respect to people across the country, oculoplastic surgeons, they all feel like aligning with other specialties is important. Making sure that you focus on things like trauma helps you with the clinical judgment, and learning happens with each and every case. So it's important that you sort of go into your fellowship with an open mind, and then go forward in your practice with an opener mind. Thank you.
Amazing. Thank you so much. Can you share? I have to play. Okay. Yeah. That was an excellent talk, Dr. Rutuja. Thank you so much for being with us. So mine is the last one. I'll be try to finish as quick as possible because time is very less time we have. So I'll be talking about journey of a cataract and a refractive surgeon. So I'm currently practice as a cornea, cataract and refractive surgeon at SRJ Netralaya, Indore. So nowadays the cataract surgery itself is a refractive surgery, and so many I have got questions by younger generations that is the cataract surgery refractive surgery too. Obviously yes, because now we have very advanced intraocular lenses, and the patient's demands are also getting becoming higher and higher, and people who are going for LASIK, and they also in future coming with cataract, and they also still don't want to wear reading glasses even for after cataract surgery. So the patient demands are also becoming higher, and awareness is also becoming. So with these newer advanced lenses, obviously we have option of removing glasses for the patients, and for that you need to be good at it. So perks of a cataract refractive surgeon, it is, as many of my friends told, that it is a main bread and butter for all of us. Almost all of your patients are happy after the surgery. There will be patients who are not happy even after giving 6/6 and N6 vision, but that is also another topic to talk about, unhappy patients. And basically it is the maximum volume of your practice. So as being a refractive surgeon or a cataract surgeon nowadays, the cataract refractive surgeon I would call, there is a very small margin of error, and you need to have high precision and high accuracy starting from preoperative management, and that starts with the biometry of intraocular lens, or in case of refractive surgery, about corneal topography and getting the correct refraction before you plan LASIK surgery. So let me just quickly tell you about myself. I'm a doctor. I did my UG and PG from BJMC Ahmedabad. Then I went for postgraduate DNB at Narayan Nethralaya, Bangalore, following which I did cataract as well as cornea fellowship from AIOC2023, and I continued there as a consultant, following which I did a short refractive training. So what are the pathways to become a good cataract surgeon? So there is no single pathway for this, right? Where so many people ask me about that, whether to go for fellowship or whether to join a charitable hospital where you get a lot of hands-on cases. So it is important you have to decide according to your personal situation, as well as financial background, as well as multiple other things where you want to practice and stuff. But wherever you go, important thing is to learn, whether it be it your fellowship, whether it be you are directly joining a charitable setup. But important thing is you need to have a mentor who can help you when you are in a trouble, and you need to, because see, when you are learning, you are going to make mistakes. You are going to make mistakes, and those mistakes are the very good teacher for you, right? And important thing is to focus on your basics during the PG. So I've seen that even during my PG, that many of my friends were running after surgical numbers, and they wanted to do more and more surgeries. So and they were missing out on learning about basics, learning about clinical diseases, clinical pathologies, learning about anatomy and stuff. So your foundation has to be strong, so that helps you all throughout your career in the future. And important thing is never run after surgical numbers, because they are just numbers. First improve your skills, your numbers will automatically improve. When I was also learning, I never looked at my numbers. First I started to improve my surgeries. Once my surgeries was taking lesser and lesser times, my number started increasing. When I started phaco, I reached topical phaco level in just 2 months. Not to brag about it, but I was not even aiming for that, but I got it as a gift when I was focusing on just learning. I also got a chance to train other people as a surgical trainer for 1.5 years, and I also did cornea fellowship at RIO. So what are the challenges as a cataract surgeon? This is what I have learned, that even from my journey, as well as the people whom I have trained, many of them, they want to do surgeries, but they don't understand biometry itself. So the important thing is to know about biometry, understanding different IOLs, understanding the phaco dynamics before you sit with a phaco machine. That is the most important thing I would believe anybody would has to know about that. Then you understand your surgical steps, and find out what kind of mistakes you are having in your surgical steps. And ultimate goal, obviously, because of the demand, as a whenever you go for a job, that can you do a topical phaco, that is the question being asked for anyone who is jumping out for and starting their career. And last thing is, this is my personal belief, that if you know how to manage your complications, then you're ready for your prior practice, right? So most common mistakes I have seen during learning phaco is the sizing of the capsular axis. So many people end up with a small size capsular axis, or even larger size capsular axis. Another common mistake is a bad and leaky incisions, which I have faced a lot during my learning period. Wrong phaco parameters during when you are starting. I mean, in a harder cataract, if you keep your power very low, I mean, it's not going to break. There is a basic thing, but even when you don't know phaco dynamics and stuff, you will make these mistakes. I also struggle with chopping, and then gradually improved. I have a video on that on my YouTube channel. Another most common mistake is unfortunately, many of my students also face this, that they were not able to detect or identify posterior capsular rent when they're doing surgery, and they still continued with the surgery and ended up making even a bigger complication. So these things are very important. You need to learn to use retro illumination of the microscope, which helps to detect the PCR, understand that there is something wrong in the anterior chamber when the PCR happens, right? So this is another just for viewers who will be watching this IC on YouTube, and I'm sharing this, that I have a video on phaco settings and parameter on my YouTube channel. You can check this out later. This is a case where I am sharing of my own surgical case. I have 1 minute. So you can see, before I started my surgery, you can see there will be so much of anterior chamber fluctuation visible, that is showing that my ports are quite leaky. And during this surgery, you'll be seeing that the iris was also floppy in this case. Sorry. Yeah, sorry. And when I removed my irrigation and my chopper, the iris was coming out of the ports. I tried to reposit it with the visco. It was still again coming out. The anterior chamber was not that shallow, and there was no any signs of rock hard eye in this case, but my incisions were really bad, and during the whole surgery the iris was out of the port, and at the end I had to suture this port. So this is the most common mistake we make while learning. Failed chopping is another thing I also faced during my learning phaco days, and the holding was not proper with the phaco prop. The vacuum was not good enough. Sometimes the chopper movement was not correct, and these all the things. Then I made few modifications, that I started taking a pause when I was holding the nucleus before even moving my left hand, and I improved the location of the tip of the chopper entry point, and that helped me to improve my chopping skills. And gradually I was able to get to the level where I wanted to reach. And you can see this is a case of mature cataract where the beautiful chops are happening. Another difficulty we face is this surge. You need to understand surge when sudden there is a break of occlusion, and I'm catching the posterior capsule in this case while eating up the last piece. Is a case of shallow anterior chamber with non-dilating pupil. I was using IRX. So this is another thing which we need to avoid. So only way to improve is learn from your mistakes. I also wanted to learn refractive surgeries, which I learned after learning about cataract and cornea. So I again went back to Narayan Netralaya and Dr. Rohit Shetty sir and Dr. Pooja Kamar, who helped me a lot with my refractive journey. Important thing is to understand your machine. We have Alcon Wavelight EX500 at our center, and it is important to know your machine, because your machine also will have some fallacies. There will be a chances of undercorrection or overcorrection, and you need to know that what kind of results you are getting with your machine, and according to that you can proceed further. And always start with the wet lab. Record your surgeries is another important thing to learn. I always record my surgeries. I'm very fond of it. Even I have recorded my LASIK and PRK surgeries and certain other surgeries as well, which helps you to teach yourself to improve your mistakes. There are after you learn basics about surgery, you will make minor mistakes, and which only you can improve if you can identify them by looking at your surgeries later. So just to share, I have a YouTube channel where I'm putting surgical teaching videos for all young eye surgeons out there, and you can check it out. And there's so many videos there. And it is also important to have fun in life, because work-life balance is the most difficult thing to achieve for anybody. And all of my presenters are there in one of the photographs here. I am very grateful to have such good friends. People, if anybody wants to connect with me for any questions later regarding any guidance, these are my contact details for anybody who will be watching this on YouTube as well. Thank you so much. So I think we are on time, and a minute is there. If anybody has any questions or any discussion from my co-speakers, anything, or else we can take a photograph and end the session and hand it over to the next session. Thank you so much for being with us.